Good morning and welcome everyone to the 76th Presidential Advisory Council on HIV and AIDS, also known as PACHA, Full Council Meeting. My name is Marlene McNeese. My pronouns are she and her, and I currently serve as a Deputy Assistant Director with the Houston Health Department, overseeing our Bureau of HIV, STD, and Viral Hepatitis Prevention. I also serve as one of the co-chairs for PACHA. And on behalf of myself and my other co-chair, Dr. John Weisman, we thank you all for joining us here in Washington, D.C. today. Whether in person or virtually, the work that we do here is heavily guided by your experience, your voice, and your input. And John and I will share more about how you can do that in his opening remarks momentarily. Just wanted to share a few updates since our last meeting. This is our first meeting of the year, and it is by intention that we are meeting here in Washington, D.C. today. Since our full council meeting last October, we have participated in a briefing with Admiral Rachel Levine on molecular HIV surveillance and cluster detection and response. You all have a copy of the PACHA resolution in your packets today, and you will hear more about that topic in a few from Director Harold Phillips, Director of the White House Office of National AIDS Policy. The EHE, the Ending the HIV Epidemic, and National HIV/AIDS Strategy Subcommittee have also been discussing opportunities where our federal agency partners can incorporate ending the HIV epidemic activities into their priority portfolios. And as a result, PACHA has met with and had invigorating discussions with leaders from Centers for Medicare and Medicaid Services and the Health and Resources and Services Administration about their efforts. And you will be hearing from them later this morning. We're excited that they're here, along with many of our other longstanding federal partners about their EHE work. We are fresh here in DC off the heels of AIDS Watch 2023 held last week, which marked the 30th anniversary of AIDS Watch, the nation's largest national constituent-based HIV advocacy event. Hundreds of people living with HIV and their allies convened in DC to share their experiences and needs with members of the 118th Congress. We applaud them for their efforts. And even in my very own state of Texas, our HIV Advocacy Day at the Texas Capitol was held this past Monday, with community advocates from across the state working to address persistent barriers to healthcare, reproductive rights, and sexual health rights. There are so many policy priorities that we have as a PACHA council and as members of the HIV community, all of which need to be addressed that will benefit and improve health outcomes. Examples including expanding Medicaid to improve equitable access to healthcare. Unfortunately, 12 states still have not expanded Medicaid. In states where Medicaid has been expanded, only 5% of people remain uninsured, compared to the 19% in states where Medicaid has not been expanded. A majority of the states that have not adopted Medicaid expansion are in the South, where approximately 45% of all people living with HIV in the United States reside. Addressing social determinants of health through housing programs and supporting economic justice and employment for people living with HIV, again, are just to name a few. On March 9th, I think it's important to note some of the updates and highlights from President Biden in his releasing of the executive budget request to Congress for fiscal year 2024. The administration released the budget in brief, which outlined $144 billion in discretionary funding for the Department of Health and Human Services. Notably, the FY24 budget request introduced a request for a new 5-year national hepatitis C elimination program to expand screening, testing, treatment, prevention, and monitoring of hepatitis C infections in the United States, with a specific focus on populations at greatest risk for infection. In addition, the budget request proposes $850 million in funding the Ending the HIV Epidemic initiative, while maintaining a proposal for $237 million in mandatory spending for a national PrEP program and a new $50 million harm reduction program housed within the Substance Abuse and Mental Health Services Administration, also known as SAMHSA. The budget request proposes to make permanent the expanded Affordable Care Act premium tax credits that were extended in the Inflation Reduction Act. It also proposes Medicaid-like coverage to individuals in states that have not yet adopted Medicaid expansion under ACA, paired with financial incentives to ensure states maintain their existing expansions. While only Congress has the power to appropriate funds, these requests signal the important work that is to be done to address the overall health needs. The HIV community applauds some of these budget priorities, but are equally concerned about the proposed flat funding for infectious diseases and the opioid epidemic, along with STD prevention and other related services. In closing for my remarks, I'd like to call out and recognize important awareness days in the month of March, since we are still in March. We have recognized National Women and Girls HIV Awareness Day on March 10th, along with National Native HIV/AIDS Awareness Day on March 20th. And for March, it's also Women's History Month, commemorating and encouraging the study, observance, and celebration of the vital role of women in American history. In the recent past, we have unfortunately lost two giants in the field of HIV, Janet Cleveland and Dr. Dawn Smith, both of whom spent much of their careers in the Centers for Disease Control and Prevention. Janet personally was dear to me and professionally a mentor of mine. I often call her the mother of HIV prevention community planning, as she focused much of her work on ensuring that locally developed services and programs be guided by the voices of community. And Dr. Dawn Smith, as many would also agree with me, was lovingly known as the mother of PrEP in this country. Her research and work shined a light on the importance of this vital tool in protecting the health of communities, but also demonstrating the inequities in PrEP access and how we must overcome them. The efforts that they started will continue to thrive, and they have left an indelible mark in the history of how the United States will be able to see an end to HIV. I would also be remiss not to mention one of my own local, personal, and professional sheroes who recently passed away in Houston, actually about a week ago. Former City Council member Ada Edwards taught me what it meant to be as a servant in public service. And because of her work, the City of Houston provided the first ever funding allocation specifically to address the African-American HIV state of emergency in the city. And that work she continued with community advocates, including packing caskets to City Hall to deliver the point that people will die, our community will die without the right support. So her consistent and persistent change will ring forever with me. We are the ones we've been waiting for, so let's do something about it. We will miss you, Ada. And I will close by mentioning one of our very own sheroes in the room. As PACHA co-chairs, John and I also wanted to take a moment to highlight a living legend and woman of distinction right here on our council. Dr. Ada Stewart, as some may or may not know, is actually Colonel Stewart. And what I recently learned was my March birthday twin. She's been a fervent advocate and ally for many years. And so we wanted to share with everyone a short video created and available on the HHS website as part of their We Can Do This campaign. So we will take a moment and show a quick video, Dr. Ada Stewart.
Good morning.
Nice to meet you.
You too, thank you. I'm Dr. Ada Stewart. I grew up in the housing projects of Cleveland, actually in an underserved area. Really did not even think about becoming a physician at that time because I didn't have any physicians around me. We never even went to the doctor. So growing up, I had no idea about going into medical school and to be a doctor. You can't be what you don't see. But my teacher brought in a pharmacist. He worked in the community and it was a part of their lives. And so I said, you know, this is something that I can aspire to be. So I entered pharmacy school. I worked for 13 years as a pharmacist, and during that time, I lost my mom to breast cancer, lost my dad to heart disease, lost a sister to, alcohol. I can list many, many others within my family who lost their lives too early to things that could have been prevented. That was really heart-wrenching. I didn't want other families to deal with, the loss that I had dealt with. And then after that, I realized I could do much more. I knew that I wanted to do family medicine, that, I can really have an impact within my community, the community where we never even saw a doctor. I can have that impact. I can have that impact. And I thought about it. I said, you know what? I think this is, my calling. I had a house, I had a car, and I was willing to sacrifice all those things to go to medical school. So I finally became a doctor when I was 40 years old. It's really all about community and service, and that's what has really guided me throughout my career, looking at those who are underserved, underrepresented in all walks of life. I'm still working at the same community health center with kids that I actually delivered during residency. I'm taking care of them today. I love what I do, and I love being able to serve the community. It's been a wonderful ride. Been a wonderful ride.
Thank you to Dr. Stewart and all the amazing women on PACHA and those of you in the room for all the incredible work that you do. We will try to wipe off the tears. Tissue is at the back of the room. And I will now turn it over to John for his opening remarks.
We're taking big sighs here. Thank you, Marlene. Appreciate that. And as I reflect back also on the beginning of the AIDS epidemic, and I think about the work that I was doing in those early days, it was also often the mothers, the sisters of folks who had HIV/AIDS who were really leading the way. So the giants go from the sort of everyday person who is raising awareness, who's supporting people with living with HIV/AIDS, to those folks with actual titles who do this as part of our calling and part of our work. So thanks to all of them. So I am John Wiesman. I am a co-chair of PACHA, and in my day job, I work as a professor of the practice and the associate dean for practice at the University of North Carolina Gilling School of Global Public Health. And prior to that, had 30 years of work in governmental public health, which is what makes me a professor of the practice. I guess I bring it into the classroom. So with that, we have talked about PACHA-to-the-People, and in this iteration of the council, this has been very important for us to get out into community and to make sure that we bring voices into the room when we are formally meeting. So yesterday, we had the opportunity to visit 3 nonprofits here in the local area as part of our going out, listening to what's happening in the field, learning the innovative practices and the programs that are being implemented with the federal funding and other funding so that we can learn as much and so that it can inform our work here at PACHA. So yesterday, we started our day in Baltimore at Reach Health Services, which stands for Recovery Enhanced by Access to Comprehensive Health Care, and met with Ms. Vicki Walters and her team there. We learned a lot about the comprehensive health home model that they are using for substance use disorder, as well as chronic disease management and health education and health literacy, how they go about doing that work, the important work that they do of helping people who are using substances to manage their cravings, to manage the withdrawal, and to reconnect again to community and to restore, and how important that is. We also learned about treatment for hepatitis C and their work with that, met with their faculty or their staff and had a chance to tour their facility. We also heard that some of the challenges they face, so when we ask what we as PACHA should be thinking about, some of the challenges they face are with reimbursement and the desire for us to do same-day services. If you are identified as being HIV positive, starting treatment right away. If you're at risk for HIV and being able to start PrEP right away. And the challenges with not being able to bill for those services on the same day if they're also treating for substance use disorders. So we've got billing challenges that we've heard about, and the so important need for safe, stable, and affordable housing and wraparound services. If you don't have housing, it is very difficult to manage many other things in your life. And if that housing isn't safe, if it isn't stable, if you're living in a place that doesn't have running water, that is infested with rodents, et cetera, it is still incredibly difficult to think about how you would focus on your health. So we heard about that. After being in Baltimore, we came back to the city and went to Us Helping Us and Dr. Hickson and his team there. This is a nonprofit that focuses on the health and well-being of communities of color and started in 1985 with volunteers providing health information for persons living with HIV/AIDS. It has grown into a very significant nonprofit with over 40-some full-time employees, focusing on the medical, both clinical and behavioral health care for HIV and for pre-exposure prophylaxis, and treatment adherence counseling. They take a trauma-informed approach to psychotherapy and also provide supports around the social, legal, financial, and other supports that are needed. They do also a lot of academic sort of research studies, helping to better understand interventions, what works, prevalence of hepatitis C and other things that are important to ending the epidemic for HIV and the other syndemics that go with it. We also were really impressed with a program that they have, which helps homeless youth develop job skills and get certified in various pieces so that they can move into the workforce and do so confidently. We ended our day at La Clínica del Pueblo and Ms. Catalina Sol's team there, where we learned about their work, which is improving the health of Latino immigrants and low-income families. And their work around comprehensive primary medical care as a federally qualified health clinic, their work around mental health and substance use disorder treatment as well, and all the work they do around community education. We heard from them the importance of primary care and having a single primary care provider and that continuity, how important that is, and the appreciation certainly for the Ryan White Care Act and all the sort of resources that come there. Also, some of the challenges administratively around these things that come with many of our resources. And again, incredibly appreciative for that funding that they have. So it was a great day. Feel free to talk to any of us who were out and about. Admiral Levine was able to join us as well in the trip, which was truly wonderful. We do want to make sure that folks know that you're able to give written public comment, and we'll mention this again tomorrow. If you want to give written public comments into the council that we will read and take into account, you can email us at PACHA@HHS.gov. So that's PACHA@HHS.gov. And if you get your comments into us by April 5th, we will be able to take a look at those. As we move into the day, we just want to remind people about PACHA's purpose. The purpose really for us as a group, as a federal advisory committee, is to give advice, information, and recommendations to Secretary Becerra at the HHS, and to lift up issues that we know are important, that we are hearing from community, that need further discussion, that need further thinking. What we are not is we do not run programs. We do not lobby Congress, and we don't direct activities. We advise, and that is our role, and we take that role very seriously, and it's an honor to have this and appreciate that this council is actually in existence. The agenda for today and tomorrow, we will be, as we know, we're in Washington, D.C. For those of you who are here with us in person, you know that. This is an opportunity for us to hear more significantly from our federal partners, and we appreciate all the work that they have been doing to end this epidemic, their responsiveness to the Council's resolutions and topics that we bring. And they joined us as well on these visits yesterday, which is incredibly important for them as well. So we'll be getting updates from them. We will be hearing from PEPFAR folks to get an update there. And then we'll spend some time again lifting up the issue of stigma and looking at both global and local and what we can learn from both of those in terms of addressing stigma. And then we will have public comment, and then we will have our PACHA-to-the-People session, which is an open session with dialogue on topics that you want to make sure that we are thinking about. Tomorrow, we will get an update from the White House, Director Phillips on the work there. We will get an MPOX update, hear about the blood donor update there in terms of donations and some of the work that we had done around the resolution a while back. Then we will also lift up the topic of HIV and substance use. We haven't spent a great deal of time on that, and we are wanting to raise that up, hear what the issues are and what we ought to be thinking about in terms of our role as advisors. And lastly, before we move on, we wanted to let folks know we've actually identified the dates of the rest of our PACHA meetings, and we want to make sure that folks know about these. So at the end of June, June 27th to the 29th, we plan to be in Arizona, again, taking PACHA out on the road to the people. Then in September 19th and the 20th, we'll actually have a virtual meeting. So we'll be all virtual for that meeting. And then we will meet again in December 5th through the 7th in Texas and Houston. So we'll remind you of that at the end of the day tomorrow as well. So that's my update. We're glad to have you all here. And with that, Kay Hayes, I'll turn over the roll call to you.
Great. Thank you so much, John and Marlene, and welcome to everyone here at PACHA and listening in virtually. I just have to say that I think Harold, Dimitri, and I had to get a tissue and share it when we saw the video. So I'm glad I had a little bit of time to collect myself before roll call. So with that, I will start with the roll call. PACHA co-chair Marlene McNeese.
Present.
PACHA co-chair John Weisman.
Present.
Greg Alton. Guillermo Chacon. Tori Cooper. Rania Copeland. Alicia Diggs. Vincent Guillermo Ramos.
Present.
Thank you. Jennifer Cates.
Present.
Mark Meacham.
Present.
Leo Moore.
Present.
Rafaela Nevadas. Laura Platero. Kayla Quimbley. Michael Sag.
Here.
John Sapero. Carl Smid. Justin Smith.
Present.
Ada Stewart.
Present.
Daryl Wheeler.
Present.
And our chat, thank you. And our Czech liaison to the PACHA, Wendy Armstrong.
Present.
Thank you. Also looking at our federal partners that are here with us. Harold Phillips.
Here.
Dimitri Daskalakis.
Present.
Adrian Shanker. Alicia Richmond. David Johnson. Tim Harrison.
Present.
Sam Wu.
Present.
Jonathan Merman.
Present.
Thank you. Robin Neblett Fanfare. Heather Hauk. Present. Erna Hughes. Timothy Holtz.
Present.
Lee Fleischer. Jessica Lee.
Present.
Thank you. Rick Haverkick,
Present.
Kristen Roja, Rita Harcrow, Edwin Walker, Gerard Redivosian. Great. Thank you. That concludes our roll call.
Thank you, Kay. Appreciate that very much. And again, great to have everybody here. It is now my pleasure and honor to be able to introduce to y'all Admiral and also Dr. Rachel Levine, who serves as the Assistant Secretary for Health at the U.S. Department of Health and Human Services. In her role, she is also the head of the U.S. Public Health Commission Service Corps, which we are pleased. And we have a number of folks who are in uniform today. So thank you for your service to our country as well. Dr. Levine, most recently, prior to this, was the Secretary of Health in Pennsylvania and also served as the Pennsylvania's Physician General prior to that. And she is a physician and has had a long career in academic medicine and focusing on this intersection between mental health and physical health and treating children, adolescents, and young adults. We're really thrilled to have you as our Assistant Secretary for Health, and welcome to PACHA.
Thank you very much. I'm so pleased to be here, and thank you for that introduction. Well, good morning, PACHA members. It's great to see you all. It was great to see you all yesterday at PACHA-to-the-People. But also thank you to all of our federal colleagues, community partners who are both with us here in Washington, D.C., but also viewing through the HHS live stream across the nation. I would also like to acknowledge that March is Women's History Month. It is Bisexual Awareness Month. And this week is Trans Visibility Week. These observances provide an opportunity to reflect on the health disparities and unique challenges related to HIV that all of these populations face. So it is certainly my pleasure to welcome you to the 76th full council meeting of PACHA, the Presidential Advisory Council on HIV/AIDS. I want to certainly thank PACHA's co-chairs, Ms. Marlene McNeese and Dr. John Weisman, for your steadfast leadership. Thank you. But I want to thank each PACHA member for all of your commitment, to all of your work, to serving on this very, very important advisory committee. I value your thoughtful input and expertise and how to address the barriers and to leverage opportunities as we all work to accelerate our efforts to end the HIV epidemic in the United States and around the globe. I know that beyond your work on this advisory council, each of you plays a critical role, an important role in our national and global efforts to end the HIV epidemic, and your dedication is admirable and very much appreciated. I also want to thank Ms. Kay Hayes, our Deputy Assistant Secretary for Infectious Disease and Director of the OASH Office of Infectious Disease and HIV/AIDS Policy, for her outstanding leadership in all of the different hats and shoes and different roles that she plays, including as the Executive Director of PACHA. I'm grateful to Kay and all of her team for their fantastic work. We are very pleased to welcome PACHA back to the nation's capital and to HHS headquarters for the first time in more than 3 years. To your credit, you have all adapted to our virtual and hybrid world and the convenings during the COVID-19 pandemic so that you could continue your important work. And then last fall, you were able to resume the PACHA-to-the-People's meetings that had begun prior to 2020 with a meeting, site visits, and a community engagement session in Los Angeles, and I was pleased to join you. So I am very pleased that later today you will have the opportunity to hear from local community members, as you did yesterday, during your PACHA-to-the-People community engagement session. These forums provide all of us with a rich variety of important perspectives and important thoughts. Now, I've only been in DC for 2 years now, but there is a vibrant HIV community here, and they have a lot to say and a lot of input and ideas for your consideration. So thank you for taking the time for this very important community engagement. I know yesterday you were able to visit several HIV service organizations in DC and Baltimore to hear about the characteristics of the HIV epidemic in their community. Thank you for inviting me to join you on one of those site visits. It was just so helpful to hear of some of their unique and some of their very innovative approaches to expanding access to HIV services, improving outcomes for people and experiencing for people with HIV to those experiencing risk of HIV. Since PACHA is back in our nation's capital for the first time since February 2020, it's important to pause and reflect. At the last PACHA meeting, you passed a resolution asking for changes in MSM blood donation deferral. As you know, the FDA released its draft guidance to the industry earlier this year, and we appreciate PACHA's resolution and your attention to this very important issue. Also, on World AIDS Day, I announced that the United States Public Health Service Commission Corps was ending its medical exclusion for people living with HIV and hepatitis B, the first of the uniformed services to do so. Thank you. I would certainly like to acknowledge the years of work by many dedicated professionals, both in the Public Health Service Commission Corps and out of the Corps, at the CDC and many other places in their work to make that accomplished. As you know, on March 9th, 2023, President Biden built on this commitment to ending the HIV epidemic and other key administration priorities in his fiscal year 2024 budget, which also addresses equity in housing, in health, in education, and economic opportunity. The president's budget invests $850 million in HHS for ending the HIV epidemic initiative to support continued efforts to aggressively reduce new HIV cases, increase access to PrEP, and ensure that equitable access to services and supports for those living with HIV exists. The president's budget also seeks $11.3 billion to eliminate hepatitis C in America through increased awareness, testing, and access to treatment. The president's budget also includes several other proposals that will complement the Ending the HIV Epidemic Initiative and support our collective efforts to implement the National HIV/AIDS Strategy. For example, the budget reduces Medicaid costs by eliminating barriers to accessing PrEP from Medicaid beneficiaries. The budget also proposes a new mandatory program to guarantee PrEP at no cost, for all uninsured and underinsured individuals, provide essential wraparound services through states, the Indian Health Service, tribal entities and localities, and establish a network of community providers to reach underserved areas and populations. I am pleased that you'll have an opportunity to hear from my friend and colleague, Harold Phillips, Director of the White House's Office of National AIDS Policy, and I'm sure that he'll have additional information on the President's budget request for HIV activities, as well as updates on the implementing the National HIV/AIDS Strategy. Go, Harold. Harold will also share updates on HIV cluster detection and response, a topic that PACHA discussed and provided recommendations on at your last meeting. Molecular surveillance and cluster detection and response are important tools in our public health toolbox, not just for HIV, but for other diseases. But we are very grateful for PACHA's efforts to raise key issues and to challenge us. We are grateful that you challenge us to reflect on how we can effectively and safely use these tools to guide the public health response to HIV and get services to those who need them faster. And additionally, I am thrilled that over the next 2 days, you'll be hearing from federal partners about their agencies' work around advancing health equity as we work together to truly end the HIV epidemic. I'm particularly happy that senior staff from both the Administration on Aging and CMS will be joining the conversations because their agencies have important roles to play in our evolving response to HIV. I believe that the wide range of federal partners you will be hearing from demonstrates our collective federal effort to reduce stigma, increase access to HIV services, and support these syndemic approaches, to name a few. Understanding syndemics, the clustering and interaction of two or more diseases as a result of social and structural determinants of health that lead to excess burden of disease in a population, is crucial in the work that we do. For example, we know that sexually transmitted infections have steadily increased over the last decade, And COVID significantly impacted surveillance and prevention efforts. We also know that when left untreated, sexually transmitted infections can lead to long-term irreversible health outcomes such as infertility, neonatal death, and can facilitate HIV transmission and acquisition. I want to acknowledge the alarming resurgence of syphilis and congenital syphilis cases across the United States. Recognizing the need to address the increasing rates of STIs while also addressing other syndemics such as HIV and viral hepatitis was why we intentionally developed and released the STI National Strategic Plan with the updated National HIV/AIDS Strategy and Viral Hepatitis Plan in 2020. In January, I was reminded that many of these same issues are evident in our work of HIV around the globe when I had the privilege of participating in the HHS Global Domestic HIV Bidirectional Learning Forum. That forum brought together 200 federal staff engaged in both domestic and global HIV responses. It was a learning opportunity for all participants who got to share insights and lessons from their work in different settings. They also identified best practices for others to consider adopting and discuss both the lessons and challenges to moving research and findings into practice. I am pleased that PACHA also recognizes the value of these conversations and that there will be a panel on addressing bidirectional learning around reducing stigma later this afternoon, along with an update from PEPFAR leadership. Finally, the Biden-Harris administration and HHS remain focused on addressing the nation's substance use crisis. Since the release of the HHS Overdose Prevention Plan, the nation has seen progress in expanded treatment capacity, lives saved from overdoses, improved access to harm reduction services, and a commitment to long-term recovery supports. But the challenges remain. People who inject drugs are at high risk of getting HIV and/or hepatitis C if they use and share needles, syringes, or other drug injection equipment that someone with HIV has used. And thus, it is a priority population indicated in the National HIV/AIDS Strategy. We also know that methamphetamine use is fueling HIV risk and transmission in many communities. Although HIV incidence among people who inject drugs has declined substantially over many years, the ongoing use of opioids and other frequently injected substances, including cocaine and methamphetamine, are threatening to the HIV prevention success. So I'm glad that tomorrow PACHA is dedicating time to hear about substance misuse and overdoses and a community perspective to addressing this critical issue. We must continue to explore opportunities to better integrate our efforts on both HIV and substance misuse. So in closing, thank you so much for being here. You have a rich meeting agenda, so I'm going to let you get to it. I am very appreciative of your time and your expertise. On behalf of Secretary Becerra and the Department of Health and Human Services, thank you for your enduring commitment as we all continue this vital work. Your passion, your experience, and your insights are crucial to our success. Thank you.
Thank you for that, Dr. Levine. Really appreciate your leadership on the many sort of syndemics that we need to be paying attention to and the intersectionality of things like gender, sexual orientation, race, ethnicity, et cetera, and how important those are to pay attention to in terms of ending this epidemic, and how our attention needs to be focused acutely on all of these issues. So with that, we are also able to hear, and thankfully from our friend, Director Harold Phillips, who is the Director of the White House Office of National AIDS Policy. Harold Phillips is going to be speaking with us at this point, and he'll also be on the agenda again tomorrow, but speaking today certainly to the molecular HIV surveillance and cluster detection response recommendations that we made at the last council meeting. Director Phillips comes to his office with years and years of experience in the HIV/AIDS. He's a friend to many folks, well known to this group, but certainly served at the HRSA, the Health Resources and Service Administration, HIV/AIDS Bureau, serving in many capacities there. Ryan White, Special Projects of National Significance, the AIDS Drug Assistance Program, and has been honored as one of those legends of pride and was again featured in the LA Pride Parade. And Harold, it is great to pass this from one Tar Heel to another. So all yours. And we won't talk basketball.
No. Thank you, John. Good morning, everyone. Oh, I have to do this. It's great to be with you to vote twice on the agenda for this meeting, but today to really talk about the resolution and cluster detection response and molecular HIV surveillance, which you all as a body really took a good look at, given some of the concerns from the community. And I would say since the resolution and also before the resolution, there's been a lot of work on the part of many of the federal staff, especially those at CDC, to look into this issue. And we have had a number of meetings and calls and emails in order to prepare for some discussion of the resolution and to inform you all where we've landed with it. I think before I start, I wanted to say that, it also gave me an opportunity to dive deeper into both the issues and the concerns and to understand them and to figure out where's the balance and the sweet spot in between both the community concerns and what we as federal entities need to do with this incredible, valuable tool. And what I walked away with, and I hope you walk away with as part of this presentation, is the fact that CDR and MHS are an important aspect of our work to end the HIV epidemic. It allows us to enhance our intersectional approach to addressing the HIV epidemic, and it's an important tool to equitably ensure target resources and services to communities that need them most. We also have some challenges. And there is definitely the challenge and the concern we've heard from the community about HIV criminalization laws. I'll talk about in all of this how CDC and we at the federal level are putting protections around sort of the collection use of the data, but we also still have to do that work on the state and local level to ensure that providers are both following those federal guidelines and also that we do the work to address HIV criminalization, which lies at the states, but we talked about it within our national strategy and its importance. So I'm going to talk about all of that and then also hopefully give a little bit of a preview of some of the work that we continue to do on this. So I think most importantly, listening to the community input and the feedback based on lived experience and a variety of ideas and perspectives has helped us strengthen and improve how we go about CDR and MHS. Colleagues at HHS and especially CDC have held more than 35 numerous meetings, webinars, and listening sessions on cluster detection and response. And also know that several subcommittee members from PACHA attended many of these gatherings. We intend to continue community engagement at all levels, from the national advocacy organizations to local advisory boards, and we want to bring a variety of voices and experiences and expertise to the table to inform program planning. Most of the community engagement happened before the resolution passed, so we were well on a path to really think about that and consider what we were hearing from the community as well. Many of you know the background on the resolution, so I'll not spend so much time on that, but I have summarized some of the key takeaways here from the resolution. It passed in October of 2022 and was developed in response to community and PACHA concerns. And special thank you to the Stigma and Disparities Subcommittee for exploring the issue and the full council for bringing the ideas forward. The resolution from the Stigma and Disparities Committee is an example of how PACHA fulfills its mission, and my office always carefully considers PACHA feedback as we carry out the work of implementing the NHAS. I think it was a friend who works in the field of HIV who said to me, "This is a very active PACHA. I don't know that I've ever seen a more active PACHA." And I just kind of smiled and I said, and that's because of the commitment and dedication of those who are now seated. And the vision of the NHAS is to ensure that our country becomes a place where new HIV infections are prevented. Every person knows their status, and every person with HIV has high quality care and treatment and lives free from stigma and discrimination and can achieve the full potential of health and well-being across the lifespan. I think it's important to keep in mind that we do have a shared vision that we might approach from different perspectives, but we do have a shared vision and the same goals. And this is important now more than ever. After years of declining HIV diagnosis, we've recently documented stabilizing rates or even increases among some populations. And it's critical that we redouble our efforts before inequities increase further. I think we all believe in this vision, and everyone here plays a part in achieving it. The PACHA members provide advice, information, and recommendations. And in my role, I coordinate a multitude of collaborators using that almost 30 years of expertise that John mentioned, and including the federal agencies, the external partners, and federal advisory committees to help realize the goals set out in the national strategy and its implementation plan. And these collaborations result in policies, programs, and actions to help the nation in achieving its goals, moving from strategy and to action. So with CDR, MHS, and EHE, I think it's important to recognize that this is a critical component of our EHE strategy, and especially concerning the response pillar. And the approaches ensure that resources are allocated toward communities experiencing rapid HIV transmission. And our goal here is to use CDR, MHS to interrupt those transmission patterns. And in interrupting those transmission patterns, really and truly provide the other sort of critical components of EHE in those communities and among those populations who need it most. Molecular data helps us identify those gaps in HIV prevention and care services, especially gaps in services for people who are already experiencing marginalized circumstances. In short, molecular data gives us another way to advance health equity in HIV. And without the data from CDC-funded state and local health departments, including molecular data, federal agencies wouldn't have as clear an understanding of the affected populations, their needs, and the potential benefits of tailored services. And here are just on this slide a couple of examples of where CDR MHS has increased health equity. In the Detroit example, a network of rapid HIV transmission was identified that included transgender women of color. During the response, a series of community meetings revealed gaps in efforts to address structural factors for HIV prevention, particularly access to housing and safe, welcoming healthcare services. Solutions to address these gaps are now underway and include status-neutral approaches to care and a mobile health unit that offers a variety of health services, including gender-affirming care, and connects community members to other wraparound services. A description of this response is available on CDC's Community Spotlights webpage. In Atlanta, molecular data showed rapid HIV transmission occurring among Hispanic and Latino gay and bisexual men. The response to this cluster provided data needed to prompt the expansion and accessibility of Spanish language materials and services. It also enhanced collaborations with community-based organizations serving Hispanic and Latino communities. CDC is developing a new community spotlight to share information about this response. And one of the things that has come out of sort of this deeper dive is the fact that we need to do a better job about communicating the successes of CDR MHS. And so a lot of that work is also already underway at CDC to highlight and spotlight some of these successes as we use this important tool. Community planning happens at various levels in this work. And I'm calling this one out because there has been, I think, a misunderstanding of the role that community has played in this aspect of the response and the involvement and engagement of community from the start. Community planning happens at various levels in this work, starting with the development of jurisdiction-specific CDR plans that are a requirement of PS 18-1802, the flagship health department NOFO, and PS 20-2010, which is the EHE NOFO. So wrapped within EHE is a community planning process and community plans for the implementation of CDR. Specifically, CDC requires that jurisdictions develop these plans. And as part of this process, jurisdictions must engage with the community in the development of these plans and use what they learn in their community engagement efforts to inform it. It's also worth noting that while NOFO language about these community engagement requirements often refers to general community members, there are also specific requirements that some of those community members be people with HIV. People with HIV are also engaged when a response is identified. They are more than key informants. They are often part of the group that plans and implements the response. Here are some examples of community involvement in CDR and MHS. Oh, wait a minute. No, that's the wrong one, isn't it? Wait a minute. All right, no. Here are the examples of community involvement in CDR and MHS. Sorry, more coffee is needed. For example, in Detroit, a network of rapid transmission was identified that included transgender women of color. Wait a minute. Yes. And I think as we do this work and the community involvement is I think we've done several things in terms of community involvement and engagement. Not only is it in the NOFO, also HRSA sent out guidance, also reaffirming the importance of community involvement and engagement in its work as well. And so I think doubling down on that piece of it is something that the federal partners have also done as part of this work and the things that they are doing. Also included on this slide, I also have the examples for Michigan and also San Antonio as well, and the work that was done, that has been done there as well, which speeds up our ability to interrupt the transmission patterns. So the examples I just provided demonstrate how CDR helps to get closer to achieving our mission to end the HIV epidemic, and successful responses require data to map the path and collaborations to keep us on that path. Some of the activities included in October's PACHA resolution conflict with our core public health functions. To stop collecting data that is used to identify and interrupt HIV outbreaks would be to neglect our public health mission and compromise the health of many of the people we serve. We need to use every effective tool we have to end the HIV epidemic. To give individuals a choice to opt out of having HIV data shared with the health department would result in incomplete surveillance. We would not know how to build our programs or how to allocate our resources to help the most people. It would also weaken our ability to justify the resources, programs, and support we need to end the HIV epidemic. And because of this, these are our recommendations that CDC cannot put into action that were part of the resolution. What we can do and will do is continue to support efforts across the country to protect molecular HIV data, to modernize HIV criminalization laws, and to ensure that CDR activities benefit the communities in which they are taking place. Although CDC will not fully enact all of the recommendations as written, they are working to incorporate many components from the recommendations. For example, although requiring informed consent and allowing opting out of surveillance data collection are not feasible, we can educate providers on how to communicate with their patients and explain how public health data is used for surveillance purposes. Furthermore, CDC already requires individual patient consent be obtained before any HIV sequences of molecular data are collected through the National HIV Surveillance System and added to a public repository. As I mentioned earlier, CDC is considering possibilities for an adaptable framework for CDR MHS activities, and the types of activities needed must vary from one jurisdiction to the next. And while a total moratorium may not be an option or even compliant with state laws, flexibilities are being considered. Almost done. As for the resolution passed in October, most of the suggestions were directed towards CDC. And I've met with CDC colleagues and discussed what forward momentum looks like. And the good news is that some of the recommended activities are already underway. And these include strengthening data protections. And when it comes to molecular data collected through the National HIV Surveillance System, CDC guidance requires that, one, the data are not submitted to a public repository unless individual patient consent is obtained. Two, the data should not be used to attempt to determine directionality. And three, the CDC limits molecular data collected to Sanger or consequence sequences. This guidance is unusual because it requires that health departments report less complete data than is currently available through next generation sequencing. CDC did not find public health benefit to collecting the more detailed sequencing data generated when next generation sequencing methods are used, and decided to limit the data reported to only the information that would help advance specific HIV prevention efforts. CDC is also updating the National Center for HIV, Viral Hepatitis, and STD and TB Prevention Data Security and Confidentiality Guidelines. These updates include aligning IT and informatic security measures with the latest technology and strengthening recommendations related to policies on the release of data for public health purposes. Let's talk HIV criminalization. Supporting states in modernizing their HIV criminalization laws. While CDC cannot advocate for states to change their laws, they can help states understand where their laws are incongruent with HIV science. We've also included this as an important part of the national HIV strategy, and have also from the White House been working to get both state and local actors to understand the incongruency between those laws and good public health. At a White House HIV criminalization forum last year, Dr. Merman clarified that work to educate prosecutors and law enforcement about HIV transmission, prevention, and the impact of HIV criminalization laws that have not been modernized is an appropriate use of both flagship HIV prevention funding and EHE funding from CDC. So we have additional resources that can help us get it done when it comes to HIV criminalization and the concerns that the community have about the connection or a possible connection between CDR, MHS, and HIV criminalization laws. CDC, in partnership with Change Lab Solutions, recently launched the HIV criminalization legal and policy tool to assist state decision makers in assessing the alignment of their HIV criminalization laws with current scientific and medical evidence and with HIV data privacy laws. The tool can also help identify where the laws could be modernized. To support uptake of this tool, the Minority HIV/AIDS Fund is supporting a learning collaborative of 5 to 7 states on how to use this tool. The tool was launched on HIV is Not a Crime Awareness Day at the end of February, and there was a national webinar with about over 400 participants in that webinar itself. Our goal in this work remains the same: to partner with public health, criminal justice, legislative systems, and policymakers to ensure that HIV-related laws are evidence-based and support public health. Other things that are underway, providing peer-reviewed evidence for CDR, including cost-effectiveness. Colleagues at CDC have added a new science brief webpage that compiles the evidence for CDR. This includes reference to approximately 100 publications from the last few years. And this is going into clearance and will be posted on the website soon. There are also a number of activities included in the resolution that CDC is working on, such as educating providers on data use for public health purposes, building a clearinghouse of CDR information and resources. For example, CDC has developed a suite of community spotlights available on their website that describe some of the successes of the community responses have had. In terms of the future efforts, other ideas included in the resolution are under consideration as CDC develops future HIV prevention programs for health departments. They're limited in what they can share right now about this work before the announcement goes out, But I know that what they have learned in their community engagement sessions and through various advisory committees, including PACHA, will be considered as they develop future HIV prevention plans for health departments. Our colleagues at CDC monitor the HIV landscape, fund evidence-based interventions, and conduct laboratory and implementation science, and help us understand which populations have barriers to services, what interventions work best, and where we need to direct resources based on data. Surveillance is the backbone of public health, and without it, we wouldn't even know how many people have HIV or whether our interventions are working. Programs, resources, funding, prevention efforts, and even advisory committees rely on having accurate information about HIV. The collection and analysis of molecular data is a critical component of this work, and we know that HIV prevention and care efforts aren't reaching everyone who could benefit from them, but our resources to conduct this work are limited. Molecular analysis informs us of where outbreaks may be forming and allow us to intervene. And in this way, it is a critical tool we use to better direct our resources where they are needed. Before I end, I would like to share that effective and appropriate cluster response efforts require strong collaboration between public health, healthcare, mental health, housing, and partners in affected communities. This also means that strong partnerships and collaboration at the federal level between agencies responsible for these activities is essential. In addition to CDC, other agencies, including HRSA, SAMHSA, IHS, and HUD, as well as their state and local recipients, have also been engaged in response efforts through interagency coordination at the federal, state, and local level. Here is an example from Boston, where multiple federal agencies worked with state and local agencies and partnered with FQHCs and CBOs on the ground. At the federal level, CDC has made great grants to health departments, while HRSA has funded Ryan White recipients, healthcare for the homeless providers, and health centers. These groups have provided services and partnered to help with CDR efforts, such as harm reduction services, including syringe services and substance use disorder treatment programs, housing advocacy and low threshold housing, outreach and case management, HIV diagnosis and linkage to care, public health messaging, HIV testing campaigns, and placing an HIV coordinator in the Suffolk County House of Corrections to expand HIV testing during incarceration and PrEP initiation. Federal agencies continue to have meaningful roles in response work as their local funded partners provide HIV treatment and PrEP, set up or strengthen SSPs and substance abuse treatment, expanding housing, and engaging with CBOs to tailor response work to community needs. Hopefully that answers a lot of both some of the issues that were raised in the PACHA recommendation and how we plan to move forward as federal agencies in collaboration with state and local efforts. Thanks.
Great, thanks for that, Harold. Appreciate that a great deal. Appreciate both the specificity that you went into in terms of the pieces that we had in our resolution, and certainly understand our role as an advisory committee. Appreciate the time that you, your federal colleagues have taken on this issue, as well as the attention of Admiral Levine, who we were able to have a discussion with as well following that. What I think I would ask and appreciate is if we can distribute your slides to the council members. I think it's best for us to take a look at those. If there are further questions, we've got more time with Harold tomorrow that we might have that, but also understand that as the director of the domestic policy, this has been given considerable consideration, and we appreciate the thought that's gone into that. And so we'll take a look at those, and if there's further questions for Harold, we can do that tomorrow. Also want to acknowledge Council Member Tori Cooper has been able to join us. Welcome, Tori. Glad to have you here. And with that, I'm going to turn it over to Marlene.
Thanks, John. And we will dive right into the greater part of our morning's agenda. which is hearing directly from, again, our federal partners on their updates toward the Ending the HIV Epidemic initiative. Ending the HIV Epidemic, a plan for America, aims to reduce new HIV transmissions by 75% in 2025 and by 90% in 2030. This initiative is being bolstered by long-term investments in our HIV programs and infrastructure. The federal government obviously is a critical partner in supporting new and innovative responses and scaling up of activities. And so I will ask my sort of co-facilitator for this part of our morning and this panel, I'll ask Carl to introduce our first set of presentations. As you can see on your agenda, we have 10 total. So we'll divide it up. How about that? We'll have 5 and 5. We'll ask them to each present, and then after the first 5, we can pause for a few Q&A, a brief conversation there. So please queue up your questions if you have some, and then we'll finish with the final 5. So I'll turn it over to Carl.
Thanks, Marlene, and good morning, everyone. I'm Carl Schmid. I'm also co-chair of the Ending the HIV Epidemic Subcommittee. And we meet as a full PACHA a couple times a year, but the subcommittee meets every month. And what we've been doing recently is bringing in some of the federal partners to get updates from them. And I just want to thank them and recognize them. But first we had SAMHSA come in and got an update. And then we had Bureau of Primary Care to get an update. So they're here today. And then PACHA leadership did meet with Chiquita Brooks-LaSure, who is the CMS administrator, to encourage them and to establish, their more involvement with ending the HIV epidemic. And one of the things that we asked for was a point person from CMS to be active with PACHA and HIV issues. And we're pleased, even before the meeting was held, she had fulfilled that and asked Dr. Lee Fleischer, who is the Chief Medical Officer, to be that person. And we're pleased that he is here today. So what we're going to do is we did ask each of the presenters to give a 10-minute opening, and then we'll ask questions. But first, I'm going to turn it over to Dr. Lee Fleischer, who is the Chief Medical Officer, CMS.
Thank you. It's a real privilege to be here. I'm also the director of the Center for Clinical Standards and report directly to the administrator, who expresses her regret for not being here, but sent me. It really is an interesting turn of events. I am old enough to remember as a medical student going to see a patient in the Northport VA where this disease did not have a name. And coming full circle, one of my key deputies actually worked in inner city Detroit, Michelle Schreiber, in an HIV clinic. So we have deep experience. If I could get the next slide, you think of CMS as a payer, but I think the last 3 years has taught everyone that we are much more than a payer. We actually have a major public health purpose in this country, and we can use many of our levers with it. So you have, and do you want me to, would you prefer I go up to the, okay. So we do pay, and I'm going to come back to that payment and how we use our payment levers, but we also regulate, and we're able to do a lot of creative things during the public health emergency. We have a lot of quality improvement. We have clinical standards by which we actually regulate all facilities that take Medicare and Medicaid dollars. Those are called the conditions of participation. We do quality survey and oversight, which many of you may be familiar with, the Joint Commission, and how we actually ensure that those facilities are doing things in the right manner. We are coming out with, it's on the unified agenda, cultural and language appropriate or person-centered care, condition of participation, which really ensures that all individuals are treated with dignity in the facilities in which CMS is able to regulate. We oversee laboratory reporting, which I'll talk about a little when I get to MPOX and the experience we had during MPOX, and it's a new emerging disease. We have payment incentives, coverage, and quality improvement. As we think about HIV services and recognize that healthcare is quite complex, and the coverage of healthcare is quite complex because there are different statutes that govern what we at CMS can pay for, what the states independently through Medicaid can pay for, and what they must pay for. And I'm going to use MPOX as an example in a few moments, as well as what in the marketplace must be at a minimum paid for. With HIV screening, we know that there is annual voluntary screening for people 15 to 65 years old without regard to perceived risk. Additionally, we have voluntary screening for adolescents younger than 15 and adults over than 65 who are at increased risk. And finally, and we're very concerned about maternal mortality and morbidity in this country and transmission, 3 voluntary HIV screenings during pregnancy. Being someone who still works clinically as an anesthesiologist, I know how important it is during those times of pregnancy that we get people on the appropriate medications to reduce risk to the newborns. What we're incredibly excited about, and this is a complex process, and I know this matters quite a bit to PACHA, is the idea of PrEP. So we were very pleased because our statutory authorities really depend on the U.S. Preventative Task Force, that when they change their recommendations, we open what's called a national coverage analysis, which leads to a national coverage decision, which changes how we can think about PrEP or the pre-exposure prophylaxis to prevent HIV, as I'm sure you all well know. So we are right now in the first phase of the 6-month period. Hopefully we can do this quicker, but I'm promising nothing today. But we have a few other priorities these days, which is considering and reviewing the evidence for oral and injectable PrEP drugs. Now, we do know there are very good reviews, as well as the U.S. Preventative Task Force analysis that went through this. We are expecting our proposed NCD, National Coverage Decision, to post in July, and that's another 30-day public comment period. So if we got it right or we got it wrong, I urge you and the committee to comment on what we propose for PrEP. And then we take those comments on a recent NCD regarding an Alzheimer's drug. We got 9,300 comments, and the team read them all in making the final decision. So we take public comment incredibly seriously. And we will make the final decision 60 days after the 30-day comment period, or about 9 months after we opened the PrEP. And we were very pleased to tell the PACHA leadership that that was happening. Now, we have come out with a national strategy on quality, which we think all individuals in the United States deserve. And equity is first, and that's certainly something of incredible importance to the Secretary and the Administrator. And advancing health equity, and as I say, we're coming out around whole person-centered care as one of our thoughts in the conditions of participation. Engaging in the communities, which is certainly Chiquita has done an amazing job, the administrator. Talk about safety, the resiliency of how the system needs to be prepared for any future pandemics. We're going to focus on outcomes, but across the entire care journey. And if we're missing, again, in our payment rules, where we talk about the directionality, if we're missing any aspect of care, needing to be both parsimonious, but incorporate everything that is of importance, please send in your comments. Something we did recently is align our programs. Medicare, Medicaid, and the marketplace, the 3 M's, as the administrator frequently speaks about, had different measures of the same outcome. For example, for diabetes, 3 different measures of what good diabetes control. We're actually put a publication out recently in the New England Journal, in which we said we are going to align them across all of our programs, and hopefully the rest of the healthcare ecosystem will do the same and we put high priority items on that list. They're called the Universal Foundation. We will be continuing to revise that, so I urge you to give us your thoughts on what should be on that Universal Foundation, which all individuals should get with regard to screening. Interoperability is a vision that the Office of the National Coordinator and all of government has, so that the data flows to all of your providers. And that's really quite important no matter where you get treatment. And we want to transform healthcare through scientific advancement. So within the HIV space and within AIDS space, we are looking at transforming what we call the MIPS system. And the MIPS is what individual clinicians, so when I practice in my setting on Fridays, I get measured on MIPS. And traditionally, there have been a lot of different things that physicians can choose to be measured on. In fact, if you're part of a large group, I'm in an academic medical center, we could be measured on any aspect of what any of those physicians do. But what we're moving towards is what we call MIPS value pathways. And that's to say that if you go to a particular physician or group of physicians, that no matter what the tax ID number is, that group of physicians will be measured on what they actually care for. So for example, as an anesthesiologist, I will be measured on either anesthesia services or outcomes around cardiovascular surgery or orthopedic surgery, depending on my practice. That what we are moving to, and this is our prevention and treatment of infectious disorders, including Hep C and HIV, MIPS value pathway candidate. You see here, there are actually a number of different measures. There's HIV AIDS, and you can see you can pick one of those 4 measures, one of 3 measures in Hep C, one of 2 measures in sexually transmitted infections, and 1 MVP broadly. There's a number of improvement activities, and you see them listed here. And finally, some cost measures. So this is really a way that we're thinking about holding the individual clinician accountable for the type of care. But if it's actually a multidisciplinary team that takes care of HIV AIDS, any member of that team can report on this, and that's really our hope. There's a number of recommended measures. You see there, enhanced engagement of Medicare and other underserved populations, MIPS eligible clinician leadership in clinical trials. This is all improvement activities. So we want to make sure that we are incentivizing individuals and they can make more money. That's the goal of MIPS, that they have a up and downside, that they do some of these improvement activities, and we have additional outstanding questions and comments. And again, we'd love your engagement in how we can think about best caring for these individuals using our levers. We want to focus on patient safety and a resilient system. One of the key things that we learned during the pandemic, one of the reasons I actually came in the middle of the pandemic as a career official, is actually the way CMS used all their levers to ensure access to care. But that access really came at a price. I still remember the way that my clinicians avoided sleeping with their families because of the fear of transmitting the COVID virus before the vaccine in those initial months. How do we ensure we instill that resiliency back into the system? And one of the things that was really a whole department, and when the previous speaker spoke about a whole of government, it was quite interesting when MPOX really became more of an issue, how each of the octaves work together. In fact, I will tell you, CDC and CMS still meet once to twice a week. We used to meet 5 times a week during the COVID pandemic. And that transition to more collaboration across all the octave of HHS that the Secretary has asked us to do is critically important. But with MPOX, we saw that there were very different authorities. This actually took us 2 weeks to figure out the complexity of how do we pay for, and as well as what is the coverage depending on which program you are. And you just see here, Medicare, Medicaid, and commercial had different authorities to say what we could. General screening was not covered for MPOX. How did we get to coverage of specific screening? And what were the rates to pay both the laboratory as well as, although the government bought the vaccine, paying for the individuals to receive the vaccine? Different in Medicaid, and one of the concerns in Medicaid was depending on what state you were in, you had very different coverage. And one of the things that the administrator thinks a lot about is how do we ensure that that coverage is not state dependent for all of our diseases. And certainly commercial plans, how are they different? But again, this was statutorily based. So the key that I wanted to really point out is the way that the government, and in many ways, because of what we've had to do over the last 3 years with the COVID public health emergency, is coordinate on all our programs. So we are talking all the time, and you see the CDC, the VA, HRSA, SAMHSA, CMS. We really do think of ourselves as part of the healthcare public health ecosystem, not just as a payer. How can we look at HIV testing report to Congress, which we send annually, and work together? How can we use our waiver, the 1115 waiver authorities? Particularly, you will see that many of our programs now talk about closing gaps in equity, ensuring that we give additional payment for those who are serving underserved communities. And lastly, about the AIDS information service. So I want to thank you for the invitation for us to join today, and look forward to interfacing with you and helping to advance the treatment and the screening in the future.
Thank you very much, Dr. Fleischer. And we're next going to hear from Rita Hargrove, who is the Director of the Office of HIV/AIDS Policy at the U.S. Department of Housing and Urban Development. And I neglected to say that everyone's bio is in the meeting materials and online. I'll just give their titles. Thank you. Rita?
Thank you. Hi, everyone. I am Rita Hargrove, the Director of the Office of HIV/AIDS Housing. And first, if I can work the clicker, there we go. First, I want to share that HOPWA is celebrating a milestone this year. It's a milestone anniversary. The program was first funded in 1992, and we've been celebrating this for a few months, and we've developed a really interesting timeline that's at the link there. And I believe everybody has the slide deck available to them, so you have this link. Next, I'd like to highlight that on December 1st, HUD awarded 20 new grants under the 2020 HOPWA Competitive Grant NOFO, Housing as an Intervention to Fight AIDS. This was our first competition in 5 years, so we were extremely happy to be able to bring something to the table related to EHE and national efforts for ending the epidemic. The total funding for that was $40 million, and we've recently started seeing the first year of outcomes and reporting, and hopefully we'll have some of that available soon. The last NOFO was in FY15, so that was the VAWA HOPWA grants. So some of you may have remembered some of the work around that. The purpose of the new HEFA grants is to provide communities with opportunities to create and implement new projects that align with ending the HIV/AIDS epidemic initiatives and to elevate housing as an effective structural intervention in ending the epidemic. I do want to point out that HUD is not funded. We're a non-funded agency under the EHE, but OHH has been looking for ways to further EHE efforts, and this is an example of how we're incentivize HOPWA grantees to coordinate with those local and federal efforts. And for the first time, these HEFA awardees will provide us with health outcome measures. And they'll report on HIV care continuum outcomes for assisted clients across different housing activities. So we look forward to being able to share more of that work with you soon. The HEFA grants were awarded competitively, and this slide shows the distribution of those grants. And there's also a link here to the summaries for each of those projects. HOPWA has responded to COVID-19 impacts in several ways. One of these was by administering a CARES Act appropriation of $65 million that we're now, for most of our communities, coming to the end of those periods of performance. Of course, some of those communities spent their HOPWA CARES Act funds within a matter of months. There are a few that still have funds available, so we are working with them now to wind down and make sure that the funds are used appropriately for the COVID-19 response. These were one-time 3-year grants to maintain operations given the circumstances at the time and that we've all managed over the past 3 years for operations and rental assistance, supportive services, and other necessary actions. There are some permanent programmatic changes and flexibilities that HUD has made based on COVID-19 response. First is housing inspections can now be completed virtually. So if you're not familiar with that, to receive ongoing rental assistance, unit must be inspected and meet some minimum quality standards. And we're able to allow communities to now conduct those inspections virtually, and that will go on. And there's also flexibility in setting rent standard for HOPWA. So we've heard from communities and during the pandemic, early in the pandemic, there were waivers around the rent standard. Many of you may have heard of fair market rent and how it often fails to keep up with actual rental costs in communities. But under HOPWA, HUD we were able to issue a notice clarifying a rent standard rule for HOPWA that allows grantees to set rent standards that are above FMR. Of course, we're working with them as they let us know those rent standards and how they will be able to utilize their budgets appropriately. So they have to look at per unit cost and their actual budget. HUD is seeking to change the HOPWA statute permanently for short-term rent mortgage utility assistance, which is currently capped statutorily at 21 weeks in a 52-week period. But during COVID-19, there were waivers, and also the CARES Act carried flexibility that allowed up to 24 months of short-term rent mortgage utility assistance. And we've received very positive reinforcement for that. That has been part of our budget request for the last 5 years. So we're hoping that going forward, the evidence from COVID-19 will help us implement that change. In late October, when the MMWR was published by the CDC that provided evidence that people with HIV and people experiencing homelessness are highly impacted with the most severe cases of MPOX, my office partnered with the Office of Special Needs Homeless Assistance Programs in HUD to publish a joint letter to HIV housing and homeless service grantees, providers, and stakeholders focused on the ways that HOPWA, ESG, and COC funds can be used to prevent and mitigate cases of severe MPOX. The letter highlighted the importance of getting people into living with HIV who are homeless or unstably housed into housing and protected through MPOX vaccination. And it really stressed using stable housing as a platform for getting individuals who have been disengaged from HIV care reconnected to care and other needed supportive services to improve their health and housing stability. The letter encourages local HIV housing and homeless assistance programs to coordinate with their health departments, other community partners in their MPOX response efforts to ensure that these efforts are coordinated and targeted to meet the needs of the community. And there's a link to that letter as well. And I think we may have more messaging coming out about that to continue highlighting the importance of that local coordination. Here's a glance at the HOPWA appropriation. This is the FY23 funding based on the actual appropriation. The annual HOPWA appropriation is divided between two programs, 90% for the formula grants and 10% for competitive programs. And you can see that of the $499, the split there. The formula grants are, of course, distributed as an entitlement program based on a formula. The competitive grants, I just mentioned the HEFAs that are part of that pot of funding. And there are some ongoing competitive grants as well that we renew on a 3-year basis. We've had an increase in appropriation over the last several years. There was a $49 million increase for 23, and this is resulting in an increase across the board for all our formula grantees. So no one is experiencing a budget decrease in 2023. And here is a glance at the proposed FY24 budget. This is the president's budget. The request is at $505 million, so that is a $6 million increase from 2023 actual. At $505 million, we estimate that 48,000 individuals will receive housing assistance, so that's direct housing, like roof overhead kind of assistance. And in addition, 65,000 will receive supportive services that allows them to remain stably housed in other kinds of housing situations and receiving other kinds of HUD assistance. The link isn't here. I think it's at the end. This was hot off the press when we built these slides. So hopefully you can take a look at that justification in that budget. I'm pleased to share that HUD has taken a whole of HUD approach to the in-house recently. Has not always been the case. Previous iterations, the Office of HIV/AIDS Housing represented HUD in all in-house and federal activities, but now we are able to work closely with other offices, including Public and Indian Housing, as well as Office of Special Needs, Homeless Assistance Grants. OHH is an active member of the in-house Federal Implementation Work Group and represents HUD officially in that capacity. And in addition, you can see here a number of collaborations between HUD and CDC, HRSA, and SAMHSA. And we anticipate that you will continue to see messages, webinars, tools, and products geared toward our local communities to build those collaborations based on the federal level work that we've all been doing. And that is the end for my presentation. I'll be around for questions. Anybody's interested in what else is going on at HUD. And I think, Timothy, you're up next.
Yeah, thank you, Rita. Rita, special points for staying within time and addressing all the questions that we asked you to address. We're next going to hear from Tim Harrison, who is the Principal Deputy Director of the Office of Infectious Disease and HIV/AIDS Policy.
Okay, great. Good morning. Thank you to co-chairs McNeese and Weissman for allowing me to present this morning. I just have a few slides. I just want to sort of set the stage for, I think, particularly the EHE implementing agencies that are coming forward after me. Doing so just by way of reminder what EHE is. I know we've probably seen slides like this before, but just sort of to level set here again. Reminder that the goal of a 90% reduction in new HIV infections by 2030 is the goal. The geographic focus is on 48 counties, DC and San Juan, which accounted for over 50% of HIV diagnosis in 2016 and 2017, as well as 7 states with substantial HIV diagnosis in rural areas. And of course, as was also referenced by Director Phillips in his talk, it's anchored by 4 key strategies: diagnose, treat, prevent, and respond. The budget, as we've heard today, just for reiteration, Congress provided more than $573 million in FY23 and was appropriated to federal agencies CDC, HRSA, HAB, HIV/AIDS Bureau, HRSA, Bureau of Primary Health Care, NIH, and the Indian Health Service. The administration's FY 2024 request of $850 million is more than $276 million increase over the FY 23 enacted level. In addition, as was referenced earlier, the administration proposes a new PrEP delivery system to provide the provide the meds and wraparound services to the uninsured and the underinsured without cost sharing. Busy slide, but what I wanted to do is just give you some highlight of the role that my particular office, the Office of Infectious Disease and HIV Policy, plays in this. People wonder, so what is OIDP's role in all of this? OIDP does not receive any EHE-specific funding, similar to our colleagues at HUD, but our role is one to promote cross-agency coordination, collaboration, and stakeholder engagement. In addition, you might recall, many of you, beginning in 2019, with the support for EHE planning efforts and jumpstart sites, OIDP has used the Minority HIV/AIDS Fund to support EHE efforts and continues to do so, funding programmatically for workforce training, capacity building, technical assistance, status-neutral approaches, and syndemic approaches, as well as programming to address social and structural barriers. And I really want to give a good thank you to our federal partners in all of this, from CDC, HRSA, and others who have really used the Minority HIV Fund to continue to innovate and really push the envelope in terms of how we respond to our HIV needs. It's also been used to support the AHEAD dashboard. And if you haven't had a chance to look at it, please do so. Go to HIV.gov. It really is an opportunity to continue to monitor EHE progress. It supports our PACE regional program involving our Commission Corps officers tasked with accelerating EHE efforts in the Southeast, South, and West regions of the U.S. And I want to give a shout out to our PACE colleagues. If you don't know the PACE program, if you don't know the work that they do in their regions, I encourage you to take a look. They really do some phenomenal work in regions 4, 6, and 9, again in our South and Southwest and Southern parts of the country. While OIDP doesn't typically do program work, we're more of a policy coordinating office. We do dip our toe occasionally in this work, and you may have seen a campaign over this past year called I Am a Work of Art, a viral suppression camp, which was launched last year, which was really designed to elevate and promote the importance of getting in care, re-engagement in care, and for individuals to seek the meds for viral suppression. This campaign, which was featured at the Ryan White program, was featured at the USCHA in Puerto Rico this past October, as well as a number of other places, was really important, community-driven, patient-centered. The people involved in that campaign were those who had made that journey from diagnosis to viral suppression. And again, if you've not had a chance to look at the I'm of a Work campaign, I encourage you to do so at HIV.gov. And you may have seen the pull-up that's out there at the registration desk. And then most recently, the HIV and Aging Challenge in rural and urban areas, which is designed to bring innovative, community-developed approaches to address many of the non-medical needs of persons aging with HIV. And this is a campaign originating from our office in collaboration with the Office of Community Living and Office of Aging. Great partnership, one that we had not done before, and so really appreciative of that opportunity to partner with them on some really important concerns and needs for those who are aging or chronically living with HIV. And the last, I want to do another sort of shout out to the issue of youth. Now, we haven't done a whole lot in this space, but we're looking to do so. We are sort of troubled by the data showing the sort of onslaught of challenges, particularly youth, LGBTQI plus youth, around mental health, substance use, and violence. And so we really want to sort of do a little bit more highlighting the importance of working in that space. Earlier, we referenced through, I should say, Admiral Levine referenced in her remarks, the importance of syndemic developments. And I really would be remiss if I did not really talk about this work, which is bridging HIV, STIs, viral hepatitis, substance use, and mental health as called out in the National HIV Strategy. OIDP is coordinating this effort with the agencies presented here today and a few others. And really special thanks to Nate Fessick in OIDP, who is leading this coordinating effort and move the feds to standardize systemic language and to develop guidance around blending, braiding, and other funding flexibilities, and identify the best examples of syndemic work. And I would argue that this is sort of syndemic work is really a critical feature, a progressive feature of how we move forward. And that the key to ending the HIV epidemic is also understanding the role that syndemic strategies are going to play. Which brings me to my final slide, representing 4 key national strategies which were referenced earlier, critical to our integrative work. In addition to the NHOS, which was released by the White House on World AIDS Day 2021 by Director Phillips, OIDP coordinated the development of the national strategies for STIs, viral hepatitis, and vaccines in collaboration with our federal partners, community partners as well. The details within these strategies serve as a reminder that our collective response to HIV must address, as Admiral Levine alluded to earlier, the clustering and interaction of 2 or more diseases, a syndemic, and it must address those upstream social and structural barriers that confound our best biomedical strategies, and must be person-centered as we strive to meet those whom we serve where they are. And I'll stop there and encourage you again to check out HIV.gov, directed by Miguel Gomez. It provides a wealth of resources on many of the initiatives that we're doing, and invite Heather Hawk to come on up.
Thank you, Tim. And next we'll hear from Heather Hawk, who is the Deputy Associate Administrator for the HIV/AIDS Bureau, and that is the Ryan White program. Thank you, Heather.
Thank you. Thank you to PACHA for inviting us to present today. My goal is to present nothing new. I hope that you all heard us say most of what I'm going to say today. So first of all, most of you are aware that we funded with our EHE funds the jurisdictions that overlap with the EHE jurisdictions. Our CDC colleagues were nice enough to make the data match to go with our Part A, EMAs, TGAs, and the states that are the 7 states. We also funded 2 organizations, a technical assistance provider and a systems coordinator provider. And later this year in June, we'll actually fund our AIDS education and training centers, our AETCs, to do workforce work for the EHE jurisdictions. So that was in FY23. We wanted to make sure that you see that the administration certainly has supported our EHE efforts. The top blue line was our request in the congressional justification. Our request for FY24 is the same as it was in 23 at $250 million. And the red line is what Congress appropriated. And we are again grateful for Congress for continuing to appropriate funds for us to be able to do this work. So as I said, our funding for EHE overlapped with our TGAs and EMAs, as well as the 7 states. We also funded Ohio as the state because we did not have a Part A in Ohio. So that is the 8th state that is funded with our EHE funds. So again, there was a very nice overlay.
And the reason we were pleased with that overlay is because it really allowed us to build on the 30-year foundation of the Ryan White program in these jurisdictions. So we had a service delivery system that already existed in every one of the jurisdictions, and we were able to add the EHE funds to the existing Ryan White system to allow our recipients to increase services or to do new things with these resources. There's just a list, so you have it as a reference. And we were certainly pleased that in the first year of EHE, which was 2020, they really did step up and provide services to an increased number of individuals. So we had a goal of serving 18,000 clients in the first year of EHE, and they actually exceeded that goal and served 19,421, either new or re-engaged clients. And I will remind everybody, although I don't think we need the reminder, that this actually started as COVID started. So for them, our jurisdictions to have been able to do this work at the same time that they were being deployed to respond to COVID, many of them, the state and local health departments, as well as our clinicians, is really remarkable. And we give huge kudos to our EHE jurisdictions for being able to deliver in the first year. So just a couple of highlights. We did publish the first year of our qualitative summary of progress. So we'd encourage you to go to our website and look at that report, because this is just a snapshot from that report, the qualitative summary. So we were able, and we culled through their progress reports as well as their plans, their EHE plans, to be able to determine what they had been doing differently. And we really did push our recipients from the very beginning to do things differently. If we had been able to reach people and get them into care or re-engaged in care, we have already done that. So we really said, you have to do things differently. You need new partners, you need new activities, different things in order to reach the people who have not yet been reached, either to get them into care or re-engaged in care. So they expanded their Ryan White services and again, did innovative programs. Because the EHE funding is more flexible than the Ryan White statute is, they were really able to use these resources in different ways than they are able to use the Ryan White resources. They expanded services through technology and structural changes. Certainly an increase in telehealth was a big shift, obviously because of COVID as well, but people really leaned into using telehealth during this time to engage people. In fact, we have a number of anecdotes of providers telling us that they probably saw their patients more than they ever had previously because they were able to interact with them on the phone, just pick up the phone and call or do a video conference. So rather than waiting for that doctor's visit or that clinic visit, people were much more engaged in their healthcare, which I think continues to this day. Again, we do know that our recipients did face unexpected barriers and challenges to implementing their EHE work plans. Things did go a little bit more slowly because of COVID, but people really did, again, ramp up. And then, again, they really demonstrated flexibility and resilience in meeting the needs of their clients. Again, we have a lot of anecdotes around, the deployment of getting people iPads so they could do the telehealth, or getting people, Uber rides in order to go to a clinic or go to a visit. So they really did become quite creative in doing that. So how did they deliver these activities? Again, they expanded access through technology and structural changes. So we had a number of jurisdictions that developed new service delivery locations. So they might have done a mobile van at this time to go where people needed them to go. They might have extended their hours with these resources, and a number of them did one-stop service models at a time when they hadn't had enough resources through our Ryan White program, because the Ryan White funding has been maintained for the last decade. And these new EHE resources allowed them to do things, again, differently and design their service delivery systems in a different way than they had been able to design them before. And as I said, we really did require them to expand or develop new partnerships. I'm not going to read this slide, it's very busy, but this just gives you a sense of all of the different partnerships that have been formed during this time. And I really, again, think it's a testament to the jurisdictions knowing that there were needs that could not have been met previously and reaching out to new partners. And we just listed a snapshot of them here, but if you cull through the reports, it's quite remarkable who they've been able to partner with. So that's the service delivery side. In terms of our workforce efforts through EHE, as I said, we also fund our AIDS education and training centers. to leverage their work that they already do around workforce training and technical assistance. So with the EHE funding that we have provided to the AATCs, they have, again, worked with the state and local health departments to figure out what the needs are in the EHE jurisdictions and increase their training programs. And many of you may know the AATC program is the place in the Ryan White program where we have prevention authority as well as care and treatment authority. So these trainings have really been around the whole of the HIV cascade on the prevention side and the care and treatment side. So they do PrEP, they do testing, screening, and a number of other things. So they've done EHE trainings. They launched an HIV prevention detailing program. They created a community health worker advisory group, and they've done a number of new communities of practice as well. And then last but certainly not least, as most of you know, community engagement is baked into the Ryan White statute. It's been a tenet and a hallmark of the program since the very beginning when the legislation was passed. So we've always had a robust community engagement effort. And in 2021, we actually did a virtual specific to EHE, we did a virtual listening session, series of sessions. So we did 16 listening sessions in 2021. We had almost 2,000 people who participated in those listening sessions. We did do 2 in Spanish. And we had our BIPIC colleagues as well as our CDC colleagues on these listening sessions as well. So I just listed the cross-cutting themes that we heard. Again, I'm not going to read them in the interest of time, but we really did get very rich feedback about what was working in terms of EHE and what some of the challenges were in the community through all of these listening sessions. And I know that my CDC colleagues will also mention this, but we are in this year, calendar year 2023, we are actually going to do a joint series of community listening sessions broader than EHE to get community perspective on what's working and what some of the challenges are in terms of HIV prevention and HIV care and treatment across the country. So again, in the interest of time, I am finished and I will turn it over to Timothy.
Thank you, Heather. Our final speaker in this grouping will be Rick Haverkate, and he is joining us virtually. He's with the National HIV, HCV, STI consultant with the Indian Health Service. Rick?
Oh, thank you, Carl. I'm really sorry that I'm not there with you in person today. Really love my time with you, and it was amazing to hear that it's been since 2020 since we were all there together in DC. Crazy to think about how much time has gone by, but thank you. I might be a little different today, what I'm going to do from the other agencies, but I really wanted to talk about something that we've developed over the last year that I think is a great for a show and tell. So first I want to thank the Office of the Assistant Secretary, OIDP, Kay and her group there, under Tim's guidance from the Minority HIV AIDS Fund. It really made this project and almost everything we do at Indian Health Service possible. In the last year, we worked with our partners from around the country to take the 3 national strategies, the HIV National Strategic Plan, the Viral Hepatitis National Strategic Plan, and STI Plan, and we wove them together in something we're calling the IndigiHOS, or Indigenous Strategy for this Endemic. It complements all of those strategies and allows our Indigenous stakeholders to formulate their own response to this endemic in their communities by incorporating local governance and Indigenous knowledge. And as members and leaders of our Indigenous communities, we encourage the use of the IndigiHOS as a process-based roadmap for all stakeholders to guide the development of their policies, services, programs, and their initiatives, and through many actions to achieve the nation's vision of ending this endemic by 2030. So our partners, in addition to the Indian Health Service, was our strong partner, the Northwest Portland Area Indian Health Board. We had Native Hawaiian healthcare agencies involved, Cardia Services, as well as many of our tribal and urban Indian health partners, who all combined energies to align the IndigiHOS with the national strategies and maintain a focus on those 4 pillars of ending the HIV/AIDS epidemic: diagnose, treat, prevent, and respond. So in IndigiHOS, we focus on promoting a holistic approach that emphasizes the balance between the spirit, mind, emotions, body, and relationships with our land, with our community, and with all of creation. So next slide, please. Thank you very much for taking my slides at the last minute. So the IHS, the Northwest Portland Area Indian Health Board, and our Native Hawaiian caucuses, in addition to Cardia Service, all combined efforts on this. I just wanted to make sure that you knew that was not a standalone project just by IHS. Next slide, please. Let me tell you about the vision. So in keeping with the National HIV/AIDS Strategy, in the IndigiHouse, we envision a world in which all Indigenous people are healthy in mind, body, and spirit. The spread of HIV, STIs, and viral hepatitis is prevented. Every person knows their status and lives free from stigma and discrimination, and every person has access to high-quality, holistic care that reflects Indigenous values, promotes relationships with each other, as well as the land and all beings. Next slide. So we use the medicine wheel a lot in our communities. Not every Native community uses the medicine wheel concept, but we used it to frame this program. And I remind you that we had a lot of partners. So we selected folks from all around Indian country, and we used the term Indian country just to mean all those parts of the America that is inhabited by Indigenous people. So obviously that means all 50 states and all of our territories. So when we say Indian country, however, we mostly mean those places where you find a larger proportion of the population of American Indian, Alaska Native, Native Hawaiian people living. And a lot of us use this medicine wheel to sort of focus our work and all that we do. Next slide. We thought it was really important also that we balance the core values that all of our partners perceive to be common across the many Indigenous communities. So you'll see those core values listed here: honesty, affirming community strengths, interconnectedness, diversity, balance, to name a few. Next slide, please. So, and in those components, we had 6 main messages. We have 14 goals. We have 66 strategies to reach the goals. Plus, we added promising programs and practices and accompanying measures of progress. And finally, we created connections that show how each section aligns with the goals and objectives from those other 3 national strategies. So we really wanted to make this a toolkit for using all 3 existing strategies, embracing them, but doing it in a very Indigenous approach. Next slide, thank you. So, and we developed icons for each one of the sections of the strategy to show how the goals relate to the types and levels of interventions. So prevention, treatment, diagnosis, and response, we all know those pillars. But then the level of interventions, is it for the individual and family, is it for a community, or is it for our healthcare system? Next slide, please. I'll walk through these fairly quickly for you, but we had some main messages, goals, objectives, and strategies. So next slide. First, we focused on sovereignty. And hopefully you've all heard that word, sovereign nation, as tribes have that special relationship with the U.S. government. Next slide. So the main message in the sovereignty section is to center Indigenous sovereignty in the design and delivery of health services, including sexual health services. Next slide. Then we talked about cultural responsiveness. Next slide. So what that means is we deliver culturally and linguistically responsive health services, including sexual health services. Next slide. Then we looked at partnerships as our next major section. Next slide, please. In partnerships, main message is to strengthen partnerships to improve systems of care for Indigenous people. So I don't think any of these so far would be foreign to any of you, except that taking those 3 national strategies and really focusing them and creating an Indigenous approach, I think is what we're trying to advocate for here. And we're working in the next year then to take this strategy and really get it to be part of the core operating procedures for our tribes, our Indian Health Service facility, our urban programs, and any other group that may be offering syndemic services to Indigenous populations. Next slide. We talked about awareness and stigma. So the next slide is the awareness and stigma main message is to reduce sexual health related stigma. Things like increased knowledge and awareness of the relationship between sexual health and overall health and well-being. Next slide. Our next chapter is clinical resources and services. And so if you click to the next slide, you'll see that our main message there is to develop capacity to support diagnoses, treatment, prevention, and response. So we really want to increase the availability of accessible and sustainable clinical resources and services across our Indian Health Service, tribal, and urban health systems. Getting close to the end now, the next slide is about data systems. If you click one more time, you'll see that their main message here is really to improve the knowledge, evidence, and practice base related to Indigenous health and well-being. We really know that in all of our communities, we have to strengthen data systems and the way we share data and the way we address information gaps. We don't know where we're going unless we really have a clear map to get there. We don't know if we've made progress unless we have a system that tells us where we came from. So clearing up these data systems, really working to share data across our federal agencies, across our service units, even within our own office building sometimes is a bit of a chore, but it's really a major part of our efforts. Next slide is we talked about indicators. The next, so indicators is the strategy includes indicators to measure progress, which align with the goals and objectives of all the various strategies. And then finally, programs and practices. So the last part of our IndigiHOS strategy is to look at programs and practices. And next slide. Those strategies include examples of programs and additional resources that help us illustrate our current work in the Indigenous communities we serve and support Indigenous communities in continuing to work towards the outlined goals, objectives, strategies, and indicators of the various strategies. And that was it for me. So thank you. I hope that was a little enlightening. We've worked really, really closely with Harold, with the folks at OIDP. Many, many thanks to them and thanks to our tribal partners. The work isn't finished. We've got a long ways to go, but I think this really lays out a nice groundwork for how we address our Indigenous communities. So any questions, you're welcome to email me. My email address is there. I also want to shout out to Andrew Yu, one of our new employees there in your room from IHS, and Oskian is on the Zoom call with us, but for the first time in IHS history, we have 3 people in our HIV STI Hep C program. So we went from 1 to 3 last summer, and we're really, really grateful. Great to have them. So thanks so much. Take care.
Thank you, Rick. Well, thank you all to our first set of speakers. There's a lot of work being done, and we're going to hear from more in a little, but we're going to take some questions. And so if PACHA members could just put up their name tent, if you have a question, that would be great. I may start with Dr. Fleischer. Thank you again for being here. And when we did meet with Administrator Brooks LaSure, we talked about the oversized importance of Medicaid, Medicare in the marketplace with ending HIV. And, we talked about the Biden administration's commitment and just like here today, it shows that it's a whole of government approach. It's really a whole of, CMS approach as well. So just wondering, as we develop, a deeper relationship with CMS, it would be great to also have contacts within each of the M's because there's a set of work with Medicaid, a set of work with Medicare, and a set of work with the marketplace. And we have distinct issues with PrEP, with treatment, with testing as well. So it would be great. And the other thing that we talked about, it's been several years since you guys are so involved in ending the HIV epidemic and in all the areas. There was a letter, I think, just addressing how Medicaid could address HIV several years ago. It would be great if since so much has changed and we have some new, technology, new policies in place, under this administration, it would be great if we could have some updates to the field, both in Medicaid, in the marketplace, and Medicare. So if you have any answers now, that would be great, but it's something that we hope to work with you on in the future.
No, thank you. And we do look forward very much to do that. One of the things that, given I have both the center and the CMO office, and that's really why I brought up MPOX, is that idea that coordination through the medical officers really, while it's great to go inside, we can certainly help. As you said, it's always useful to coordinate. So we'd be happy to bring the right people to the table because it is different authorities, but we want to be what this administration is really focused on is that coordination across all of them and looking at what we can do uniquely by looking at opportunities and really pushing the envelope for certain things within our statutory authority. And we'd be happy. There's a medical officer named Jessica Lee in the Center for Medicaid who has been working on this. She is a pulmonologist, and she's on the phone, and a very close colleague at the same institution, so I'm sure she's more than happy to work with us. But one of the things we found is that we are much more effective when we work across centers, and we now have a structure to do that.
Thank you. We appreciate it, and we'll be following up. Marlene.
Yes, and thank you, Dr. Fleischer, and all of the panelists. I made copious notes, mostly about the wonderful activities that are taking place from your perspective as it relates to ending the HIV epidemic, particularly the education and support you've been able to provide directly into communities. But I guess I wanted to raise a bit of an issue and awareness around something that we're seeing happening in Texas. I was just recently alerted to it before this meeting. And so I just wanted to hear maybe from Dr. Fleischer or anyone around the table. There's been a problematic issue with a local medical health insurance marketplace plan. Quite frankly, that decided through a sweeping policy change at the beginning of the year to no longer offer coverage for single tablet regimens for treating people living with HIV, and is forcing providers and patients to solely revert back to multi-tablet regimens. And for all the reasons I don't have to explain to this table, how problematic it is. And so certainly just wanting to hear some perspective about next steps and actions that could be taken regarding at least this one particular insurer. I'm afraid others may follow, but just wanted to raise that awareness today.
I think the best thing to do is raise the awareness and get it to myself, and I'll make sure to others. I usually don't comment on anything that could end up in either rulemaking or the Department of Justice or the Office of the Inspector General. So it's best to make us aware, and then we certainly, I can assure you, the administrator will want to look at ensuring, particularly if there are equity issues in which are the reasons that this is done.
Yeah, medical reasons too, as we all know. Yes. Yes. Impact. Sorry.
Which impact? Yes.
Great. Thanks for those presentations. And to all of you who presented and who will follow, one of the things I guess that's very much on my mind is with the end of the public health emergency coming soon in terms of the actual declaration, those things that you found that worked, and I think a few of you may have mentioned some of those, with the waivers or whatever that were allowed during that time, what are we doing to make sure those can be permanent? And some of those things, my guess, require maybe statute changes. Some of those things might be rules, but I'm very concerned that we don't revert back to things that we found were just not as efficient or useful. So it's a pretty big question, and maybe it won't all get answered today, but anything you're doing in this space would be really helpful to know.
Is the 800-pound regulator in the room? So we have undergone under John Blum, the principal deputy's oversight, looking at all of the regulatory waivers, but recognize that except in the president's budget, the agencies can't ask for, as you say, statutory changes. So I would urge you to urge the president if there are things that we know about. The other thing that's really important to recognize is crossing state lines, some of the unique things so we are changing regs, and we did expand through our regulatory authority or extend some of the waivers around telehealth, et cetera, that we were allowed to, but there are limits to the authority much beyond about a year that OMB, as we've talked about, OMB and others have allowed us. But the other thing is the practice of medicine is a state-based regulation. And, we talk a lot about the limitations, especially in behavioral health, around the issues of crossing state lines. So I would urge individuals to also look at how the states could potentially allow some of the regulatory flexibilities that we have on the payment and the oversight side to really be pushed down to the individual practitioner.
So I think I covered in the presentation some of the flexibilities that HUD has been able to implement for regulation. But we do continue to ask for that longer term for short-term assistance, and that language is in the FY24 congressional justification. If you would like to review that and consider that. I'm trying to think of how to word this. Because the CARES Act funding that HOPWA was appropriated was a one-time, sort of one-shot response to COVID, we did see thousands of households assisted by that one-time funding. And it would be extremely helpful to make sure that we're able to continue that level of assistance with ongoing HOPWA appropriations.
So I think one of the things we have been doing, John, is trying to amplify what's worked so that other jurisdictions, whether they're EHE jurisdictions or non-EHE jurisdictions, can learn from some of those best practices that either came from COVID or came from having the EHE funding. So we're doing, quarterly webinars around that. We've got our training and technical assistants and our systems coordination provider that are going out and doing a lot of that amplification to help people understand what's working. I think because the EHE funding for us is more flexible, people have really been able to, figure out what's going to work in their jurisdiction. The one thing I would say from COVID that we really are strongly encouraging our jurisdictions to think about is the flexibilities that people had around eligibility and enrollment determinations. So people started doing those electronically. They would accept an electronic signature or not have the person come into the office. They would do it remotely. So we really want the jurisdictions to take those best practices and enhance the customer experience through maintaining some of those practices that happened because of COVID. So that's something that we are talking about, and again, trying to amplify where we saw those best practices.
Can I just lean into that comment about enrollment post PHE? Because the administrator just had a meeting with all the major insurers about best practices, because a lot of people will be unenrolled but are actually eligible for the marketplace and for significant subsidies. So if you have any ideas, we have a group that's really dedicated. Jeff Wu and our marketplace group would be happy to ensure in different areas how beneficiaries understand or individuals understand how to re-enroll.
Justin?
Thank you. So I have two quick things. First is just a comment to Rick Haverkate. I was really inspired by the way that the Indigenous House really incorporated elements of culture, elements of a very kind of holistic approach. And I feel like that's an inspiration for us to think about how we can do that throughout our response. So just wanted to offer kudos on that. And I thought that was really fantastic. My question is for Dr. Harrison. I was really inspired in your presentation to think about some of the work that you're doing around blending and braiding funding. We know that philosophically we're aligned on really having a much more status neutral approach, but often we know that the siloed funding kind of sometimes prevents that from being implemented on the ground. I'm just wondering if you might be able to speak to the types of activities that you're developing and thinking about in that particular work stream. I know that's still very nascent, but just wondering if you have any early thinkings or leanings about what that could look like. Thank you.
Great question. I would emphasize nascent. I think what the approach has been for this whole syndemic conversation is to really, even though we know that it's going on already, we are trying to get a handle of what is it first, and get some cross agencies, some mutual understanding of what it is. And so that work group has been spending some time just sort of getting to some sort of consensus about what it is that we want to really focus on and what those areas. And one of them, of course, is the issue of funding, which is a big one. And I think the agencies that are really looking at, for example, the recent announcement around a status neutral, and that the CDC and HRSA launched, is to sort of, I think, an end to like what are the sort of steps you take to get there. It may not be appropriate, obviously, for all jurisdictions, but I think it's one of the sort of ends into sort of setting up a construct where you provide an opportunity for the programming and services that follow to be able to then talk about the funding, the braiding issues of funding. It's not an easy thing, as you mentioned, because there's the silos that we have around funding are challenging. I think EHE provided some ends, I think some flexibilities. I think the agencies like HRSA and others can speak more in terms of some of the things innovatively that they're considering. But clearly the sort of siloed structure is something that we're going to have to really sort of talk about and address. But the agency can speak more specifically to how they're sort of thinking through some of that.
Thank you very much. Let's give a hand to the first five again. And I think we're actually on schedule, and I'm going to turn it over to Marlene.
And I'm going to tinkle with the schedule just a bit. We didn't have it built into the agenda, but I think it might be good for us to take about a 10-minute bio break. We'll do a hard start again in 10 minutes. But if we can take a quick break, thank you so much.
Produced by the U.S. Department of Health and Human Services.